Well, it's all about life, love, and the pursuit of happiness and going inside EMS. I am your host, Chris Cebollero, and with me always is the man of the hour, too sweet to be sour. The ladies know he's the man with the power, the one we call Kelly Grayson. Kelly Grayson, KG, what's going on?
It's same stuff, different day, man. It's actually what they call a warm summer up here in the North Country. I think it's kind of cute that they think this is warm, but warm enough now that I have to turn my air conditioner on in my upstairs office. So
I mean,
it's
that's just craziness. What is it like? It can't be more than 70 degrees up there.
let's see. Well, the temperature has dipped into the 70s at night, but right now the temperature is 80 something degrees.
Yeah, I was in Lexington, Kentucky, and it was like 71 degrees. I'm like, what the heck is going on? Don't they know that this is summer here?
Yeah, don't they know that they're in the South? It's
Yeah,
actually 74 degrees in Fort Covington right now, so it's all good.
that's just crazy talk, kooky talk. That's what I say. It's kooky talk.
We're going to have some rain later, so that's probably why it's cooling off. But it's been up into the 80s for most days and got up into the 90s for a week or so there. So,
So, Kelly, I had the opportunity to speak at the Links 2025 conference in Lexington, Kentucky. Ashley Powell, good friend, invited me there and, talk a little bit about leadership. And I asked the question, I drove home from Lexington, Kentucky. It was like 47 and a half hours from Lexington, Kentucky to St. Louis, Missouri. It was, I mean, it's just
and 47 of it was from the Texas state line to home, right?
well, I mean, I wasn't in Texas, man. It was just going from Lexington to St. Louis. I mean, I think people say it's a 5.5 hour trip,
I got you.
but I think it's more like 57 hours, but I have to
Yeah.
do that. So, but anyway, one of the things that I brought up and I started to think about on the ride home, and I thought it would be a good show to talk about, certainly is pediatric. And I think we focus on pediatric airway today because I think that that's one of the things that we
Yep.
need to kind of pay attention to. But I asked the question in the class, Kelly. I said, what is the one call that gives the paramedic and the EMT the most trepidation?
Pediatric code.
But one of the things that I said was a couple things. The first thing I said was, as their leader, if we know that that's a weakness for them, what are we doing to help them make it a strength? Because when a mother hands you a 3-month-old that's in cardiac arrest, that's not the time to figure out you're not comfortable in the arrest. And their failure, we become culpable in if we know that that's
Yeah.
a weakness for them. But I was thinking about this on the way home when I was thinking, as I was preparing this show, um, why is that still a weakness? Why are we still saying that after 20 years that it gives the paramedic and EMT the most trepidation? Why hasn't this become a strength in our EMS toolkit, in our EMS skills, in our EMS knowledge, in our EMS ability, if we are still saying that this has some type of challenge? A few things in EMS, Kelly, create more stress than managing a pediatric airway.
Yep.
And it's rare, it's high stakes, and it can rattle even the most experienced medic. But why is it still an issue today? And that's what I want to be able to focus on. But before we get started, I'd be interested to know your thoughts.
I think the high stakes are the biggest part of it. But along the way, in our education, we try to teach people that children are different than they're not little adults, and that's true. But we've gone too far in that direction. We make out like children are some special subset that requires its own unique set of skills. And the things that we're doing in a pediatric code are the exact same things we're doing in an adult code. We're just doing it with more finesse and with a smaller patient. And the drug dosing is a little more complex, but we have aids to help us do that. This is a conversation I had with Pete Antevy a while back. I said, why don't we give kids the same fighting shot at a resuscitation that we give adults? And one of the big things is we teach people that kids are different and that we have to handle kids different. And that mindset, I think, frightens a lot of people. And I think we kind of need to go back and go, look, it's a patient. You do the same thing on this child that you do on anybody else. And they're skills that you haven't just learned them. You've been practicing them on human beings for however long your career is. But the rarity, the fact that they're so rare, and they're high stakes is what feeds our anxiety. We're only doing, what is it, 10% of typical ambulance call volume is pediatrics, and of those 10%, 10% of that is high stakes and critical patients. So literally 1% of your call volume is a very sick pediatric patient. Then again, 1% of your call volume is usually adult cardiac arrest, and we do okay on those.
Yeah. And I got to tell you, I think Dr. Antevy is, Pete's a friend of the show, and he's done a lot for this space. And I changed the way that I handled pediatric arrests after his mentorship and his teachings and his guidance, where I used to just scoop this kid up and I just used to put him in the back of the ambulance and drive as fast as I could to the hospital, doing my stuff while we were there. And very calmly, in a discussion with Dr. Antevy, he's like, "Why are you doing that? What are you doing it for? Take your
Yeah,
time, get your airway, start your line, give your medications, make a transport decision, and then go." And it did give me a little bit of more confidence in this as well. So I think he's done a lot, and we need to have him back on the show. But, you said it yourself, kids aren't little adults, right?
yeah,
But they do have more challenges. They do have bigger tongues. They do have floppier epiglottis. They
mm-hmm.
do have smaller airways. I got to tell you what, the little baby head with the two balloons for lungs, it
That's
never
ridiculous.
prepares you. It never
Yeah,
prepares you. And I say this every single time. It just amazes me at how small the pediatric airway actually is.
yep,
Their oxygen resolve, I'm sorry, their oxygen reserve is tiny. They desaturate in seconds, not minutes when it comes to an adult. That's why these calls are so stressful. And since they're rare, most providers don't get comfortable with managing them. But the
yeah,
biggest question is why?
yeah. I think because it's so rare. Big tongues, floppy airways, all those things that you mentioned, they're a matter of how you finesse that laryngoscope, how you hold it, how you wield it. It's just a matter of finesse. You use a different technique slightly with a pediatric patient than you do with an adult, but it's not a new technique. It's not something you're just learning how to do. Um, if your only experience is on a mannequin once a year and it's that head with two balloons, you're not going to feel comfortable. We need if you're going to feel comfortable with it, you need high fidelity pediatric mannequins and scenarios and codes just like you would any adult practice. We don't see them all that often. I've been lucky in that the past couple of paramedic programs I've been involved with have those high fidelity, hyper realistic pediatric mannequins that give the student a little better idea of exactly what they're going to be facing. And the first time you use one of those, it's a bit of a culture shock. If all you're used to is the Laerdal head on a plate.
Yeah, I agree. You talked about intubation, and there was a landmark trial by the New England Journal of Medicine with the Journal of the American Medical Association, a trial, and it found that there were no, pardon me, it found that there were no survival or neuro benefits for field pediatric intubation over good BVEM ventilation, none. So when we think about this, Kelly, from the standpoint, and I'd like to get your opinion on it. And Pete, Dr. Antevy, where are you when we need you? I mean, we probably need you to help us with this discussion here. But when we think about intubation, we think about the high risk of intubation. We think about missed tubes. We think about hypoxemia. We think about bradycardia during attempts. What am I missing here? To be clear, BVM and supraglottics are safer and more reliable and more consistent. How come we're not making that transition?
I don't know, because we've also known for quite some time now that BVMs and supraglottics to get you through an arrest are just as good as an endotracheal tube and in an adult. But if the study you're talking about is the LA and Orange County pediatric intubation study by Marianne Gauchi Hill, it demonstrated some things we need to understand and we need to learn and internalize and make this our practice. But it didn't demonstrate some things they thought it demonstrated. First of all, when they looked at this study, they compared pediatric intubation versus pediatric BVM, and they randomized on a odd even day basis. But the thing is before they put this study into place, they had like an 8-hour course on pediatric airway management, and 6 hours of it is good BVM practice and positioning and how to do good slow BVM ventilation, squeeze, release, release. And then about 2 hours of it is, oh, here's how you tube a kid. And the paramedics in this study had never tubed kids before that. It was not in their scope of practice before this study went in, before this study. And the other gaping hole in that is the vast majority of paramedics in that study never got a chance to intubate a kid. But there's one thing it really did prove very, very well. BVM works. It's for a short distance to the hospital. It's going to get you through a code just as well, and probably with less stress if you're not trying to intubate, than a endotracheal intubation. It's going to be better. But does that necessarily, can we extrapolate to mean that we shouldn't be allowed to intubate kids? I vehemently disagree. I do agree, however, that we suck at it, we're not practiced enough at it, and we need to get better at it.
Well, let me ask you this,
Because there
though.
are some kids that BVM is not going to work for.
But let me ask you this, though. I mean, I think you touched on it. And, one of the things that if I had my way back in the old days, we were a system when I worked up in St. Louis, North St. Louis County. And one of the things that I was going to work on was I was probably going to stop intubation in the field. Why? Because when the first responders got on scene, there was no reason they couldn't put in a supraglottic airway. When we arrived on scene, airway was secure. We were doing what we needed to do. It's not about the inability or the ability for paramedics to intubate. It's the ability for us to do what we need to do for that patient. And it's not having to intubate somebody 100 times or 50 times with our ego to try to get this try to get this patient intubated. But I digress.
Yeah.
So now when we start to think about this from a supraglottic airway standpoint, you talked about intubation. You're saying that we should still be allowed to intubate pediatric patients.
We just need to be better at it.
Why not a supraglottic airway?
Oh, I'm for the purposes of a code, the vast majority of the time, supraglottic airway is going to work. I'm a fan of supraglottic airways, and I think we need to use them more. But here's an ugly little fact. Most EMS systems that you go to that have those supraglottic airways as a backup, maybe King tubes or iGels is the current flavor of the month. They carry them in the adult sizes, but they don't carry them in the pediatric sizes.
Some
the
do.
rationale,
Some do.
we don't run enough pediatric codes to make it worthwhile. And that's the same rationale they use to not have Antevy kits or Braslo kits, if that's what you want to do. They don't have all that dedicated equipment and those tools to make that code easier because they just don't run them enough. Yeah. And that's the rationale why you should have them. You just don't run them enough, and you need every tool and trick you can use to make it not be a Charlie Foxtrot. Yet we don't have a lot of those places. They're driving around with a kit of iGels, but they don't include the pediatric sizes. That's a mistake in my mind.
Yeah. All right, let's switch gears. Let's talk about training and competency. So, we think about this from a confidence standpoint, right? We know that it's the confidence. We're not trained that deep in paramedic school about dealing with pediatrics. We don't get these pediatric calls. When we get these pediatric calls, they're few and far between. I think in my 30-year career, maybe 10 pediatric arrests that really I had an opportunity to make a difference. That wasn't SIDS, those cardiac arrest calls or the pediatric arrest calls first thing in the morning, what the heck, what am I going to do here? Exactly what it's going to be, right?
Yeah.
But now when we start to think about training, when we start to think about competencies, if we're continually to train, if we're continually doing skills on mannequins, are we really not prepared to take care of these kids? I mean, here's where most systems, I'm going to make a comment that probably isn't going to be popular, but here's where most systems, I think, fall short. If you want the medic to intubate kids, you need OR time, you need cadaver labs, you need high fidelity simulation, you need to practice, and you need to QA that practice. Most systems just can't provide that. Without regular exposure, intubation becomes unsafe. And that's why I'd argue if you can't maintain your competency, you shouldn't carry the skill. And that's probably not going to be a lot of favor with a lot of folks out there.
Well, I agree with you. I imagine you expected me to
Oh
disagree,
my goodness, stop it.
but no, I do agree with you because this is one of those things. There are pockets in the country that have good intubation success rates, good pocket first pass intubation success rates, be they adult or pediatrics. But the majority of the profession sucks pretty bad at it. And we need to quit believing and listening to our own press clippings and understand that it's something we need to get better at. And how are we going to get better? It's got to do something different than what we're doing now. We need to go back to that skills maintenance and competency. If you don't get X number of successful intubations in a quarter or biannually, then you need to go into the OR and help intubate. That's not an insurmountable obstacle. I know of EMS agencies that have that very thing in place. 25 years ago, when I worked for Darbone Ambulance, we were a little mom and pop company with no resources, and we had that. You know, we had that, and we were the ones that got RSI added to the Louisiana State scope of practice. We set that up, and our insurance company didn't freak out. As a matter of fact, our insurance company gave us a break because we were training people better and had some mechanism in place to maintain competency.
Did you have
When I
any
talk,
insight, Kelly, on how that helped your system?
yes, it helped a lot. When I proposed, well, we'd been doing RSI for about 6 months before the state caught us. We didn't, we figured it's meds, it's intubation. We do both of those already. And then the state says, no, you cannot do that. You need to petition the state to allow it. And when I started looking, and I knew that if you're going to get something passed or get something past a committee, you have to anticipate every question and every objection, have a ready answer for it. And in looking at our training and our success, I looked at our company-wide success rate, first pass success rate at intubation, found out it was only 84% or something like that. Not good. I mean, it's what's that?
Better than the
That's
average.
considered good now,
Yeah.
but that sucks. That's like good, a crap sandwich is good if you put enough mustard on it. But it was only 84%. And then when I broke it down further, I realized that it was 98% without two medics. Two medics had a less than 50% first pass success rate.
Interesting.
And when I went to those medics, I expected them to be, bristle at me approach them with this, and they were actually ecstatic. Somebody's going to help them get better at intubation, and they did. But that's the kind of thing that if you're not QAing, if you can't track it, you can't or measure it, you can't improve it. So I think that doing more things like OR rotations, or if you can't do OR rotations, then with the EMS agencies in your area, form a consortium where you can buy and use a high-fidelity skills mannequin.
Yeah.
And work it that way. Heck, my last paramedic class, my third paramedic class, I got a contract with a local animal shelter for pediatric intubations because no one was going to
cats or ferrets or something.
Euthanize cats. It's gross. Some of the students wouldn't want to do it, but these cats were going to be euthanized anyway. So we got a room next to the kill room, and they would just bring the cats right over, and it was alive 5 minutes ago. It sounds gross, but it's not like we were being cruel to animals. They were going to be euthanized anyway. But it improved their skills in pediatric intubation, or their comfort level.
Sure. And let me ask you this question, Kelly, because I don't have experience in this, and you being more active in the field than I do. Talk to me about video laryngoscopy in the pediatric patients. Something we can do, something we should stay away from. Do you have any experience
Nope.
with it?
No, I don't have any personal hands-on experience with video laryngoscopy in a pediatric patient, but it's a game changer everywhere else. And I find it kind of odd that we haven't looked at pediatric video laryngoscopy really hard yet. We know that it's almost a cheat code at airway management. Maybe it's time to do that for Dr. Gauchi Hill to redo that study and compare video laryngoscopy to BVM ventilation. and understanding that BVM ventilation is just fine the vast majority of the time. I'm thinking about when an endotracheal tube is needed for that tiny fraction of pediatric patients. Yeah, I think it would be pretty awesome. And there are video laryngoscopes that have you can pick one that has whatever kind of blade you want. Hyperangulated blades, the blades that have similar geometry to your traditional blades, so there's not much of a learning curve to switch over to video laryngoscopy. Yeah, I think that you can find the video scope fairly cheaply nowadays to improve your success rate on kids.
Yeah, I'd love to know if anybody out there is using video laryngoscopy with pediatric patients, or if you've had experience with it. I'd really like to be able to hear what that was like for you. But, Kelly, we've been going for a little bit now. And if we think about, closing and the takeaways, I think that my bottom line basically is that pediatrics needs to stop being the call that gives EMTs and paramedics the most trepidation. The airway is managed when the patient is oxygenated, not when there's a tube in place. If your system can't keep medics competent with pediatric intubation, don't gamble with it, right? So you train the heck out of BVM, you train the heck out of using supraglottic airways, and that's what's going to save lives. And I think that we have to now change the paradigm of saying that EMS and EMS professionals are not confident with pediatric calls. We have to read, we have to study, we have to research, and we have to know that when that balloon goes up and we put, and we have a pediatric patient that needs our help, we're going to do the best that we can. And we're not going to worry about that this is our first one and, first one this year. We need to be able to be comfortable enough to know that we can handle it, that we can manage it. And I think Dr. Antevy has done a lot for the career field to make us feel that way.
Yeah. And I think for my part, one of the keys to gaining is remember that it's just a patient. That's a human body. You've been trained how to work on them. The skills that you use, IV or IO access, medication, intubation, or airway, let's just say airway management. We know how to do that. We're just doing it on a smaller body. If you can tell yourself that and convince yourself that, take a breath, it's going to be okay. If you do your best, then the outcome will be what the outcome is. I do like the Antevy card so that we can actually start prepping in our mind and getting into resuscitation mode on the way to the call before we lay our hands or our eyes on the patient. But I think if you remember that it's just a patient, you're going to be fine. And in the meantime, if you can't convince yourself that it's just a patient, get a lot more education. Get a lot more education. But hey, that's what we think about it. We'd love to hear what you think about it. Does pediatrics petrify you? What about pediatric airways? Do you think that intubation should be a skill that we still manage, we still hold for pediatric airways? I'd love to hear your thoughts at the show at ems1.com. And thanks for tuning in. And thanks for tuning in to myself and Chris Cebollero. We'll catch you guys next week.